Welcome, everyone. So, this is a refreshed HIPAA review, and we built it specifically for EMS clinicians, EMRs, EMTs, AEMTs, and paramedics. What we're going to do is take the federal HIPAA rules and translate them into the calls, the radios, the devices, and the handoffs you actually deal with every shift. Just a heads up, the content in today's talk reflects the 2024 Reproductive Health Privacy Rule, the May 2026 HIPAA Security Rule update, and the OCR enforcement trends we've seen so far throughout 2026. Okay, so here is the arc real quick. We're going to start with the foundations, what HIPAA actually says and what PHI actually is. From there, we'll dig into the two behaviors that drive the most avoidable EMS violations: personal device use and social media. Then we'll walk through your obligations, run a real chest pain call from dispatch all the way through post call, and hit the edge cases that always come up: law enforcement, MCIs, the state law overlay, patient rights, etc. We'll wrap up with the safeguards, the May 2026 security rule update, the breach response playbook, and where OCR's penalty landscape sits today. That's what's coming up today, so hang tight. Okay, so quick word about me. I'm Dustin Weber. I'm an EMS liaison for SSM Health St. Mary's Hospital in Madison. I'm a critical care paramedic, and I've worked every level of EMS. I started as a volunteer EMT basic, moved through what was then called EMT IV Tech, today AEMT, and I've been a paramedic and a critical care medic since 2015. Along the way, I've worked volunteer, municipal, hospital-based, and private services, and I still run as a full-time paramedic. So my goal today is pretty simple: give you a practical, defensible HIPAA decision-making, knowledge base that you can actually use in the field. If you do have any questions about today's talk, please don't hesitate to reach out. My email address and phone number are on the slide. Let's get into it. So just the standard disclosure here: I don't have any financial or commercial conflicts of interest tied to this program. I don't know who exactly would want me. If you do want me to have a relationship with you to talk about HIPAA, we can talk, but there is no relationship with any vendor that I'll mention today. Anytime I reference a federal regulation, OCR guidance, or a published case, it's cited, so you can go read the source material yourself if you would like to. Foundations, and this is all right, so today's talk is broken into a number of different sections. The first section that we're going to cover today is called Foundations, and this is essentially HIPAA in plain English to hopefully make it understandable, okay? And what's really interesting about HIPAA is a lot of people take HIPAA as just a privacy rule, and it certainly has that component. But believe it or not, it has just as much to do with billing and insurance as anything else, because as we know, money is what makes the world go round. So we'll talk very briefly about that side of it, but mainly we're going to be focusing on the privacy stuff here in today's talk. Okay, so let's set the table. HIPAA, which is 1P, 2 A's, not the other way around. It's the Health Insurance Portability and Accountability Act, which was passed back in 1996. The privacy rule kicked in 2003, and the security rule followed in 2005. Then in 2009, the HITECH Act added the breach notification rule and really kind of cranked up the penalty for violations of this. And most recently, Health and Human Services, which I'll refer to throughout the talk as HHS, dropped a major security rule update in December of 24. And that just went live in May of 2026, which it's June of 2026 when I'm recording this. So literally just last month from current Dustin's perspective. So, and that change that went into effect was driven by the Change Healthcare ransomware attack and a string of other large-scale breaches. Bottom line for us: if your EMS agency bills electronically, you are what's called a covered entity, which means all three rules that we're going to talk about apply to you. Okay, so here we go. Let's get into it. Okay, so here's the thing. EMS providers face HIPAA challenges most clinic based or hospital based folks just don't. The most common informal violation, that is the post call story. This is where you say, "Hey, did you hear what happened to Sally last night?" That can absolutely be a HIPAA violation, even between coworkers, if the disclosure isn't for one of three things, and that's treatment, payment, or operations. And safeguarding covers every form of PHI. We're talking about paper trip sheets in the cab, the open EPCR on your laptop, the 12 lead on the monitor, the cardiac strip taped to the cot rail. If you step away from a device, lock it. If you leave a paper face sheet, secure it. And don't forget the EMS specific stuff. We're talking about scene photos, dash cam footage, et cetera, et cetera. Treat all of that as PHI. And I want to talk a little bit about a couple of different things. So, some challenges that really just hit EMS differently. Public scenes, right? It's really hard to uh, keep everything private because we're not working in private rooms, right? And because of that, what we call incidental disclosures multiply. Okay. We also have issues where we're using radios to communicate, right? So anyone with a scanner or internet connection can hear what we're saying, which means we need to use the minimum necessary rule. And again, we'll get into that. And mobile workflows, right? We have PHI on our tablets, on cardiac monitors. There might be a reason that you have it on like an ambulance based smartphone. And then, of course, we have to give handoffs, right? When we transfer care, whether that is for an ALS intercept at the bedside in the ED. Name the place, right? So there's some things we need to do there, like draw the curtain, lower your voice, things like that. So we'll get into all of those as we move through the talk today. So what counts as PHI or protected health information? Um, Basically, any individually identifiable health information that you create, receive, maintain, or transmit in any form. And in EMS, PHI is way broader than just a name plus a diagnosis. The 18, and there are 18, the 18 HIPAA identifiers include names, addresses, every date element other than year, phone and email, medical record numbers, license plate numbers, device serial numbers, biometric identifiers, full faced photos, and any other unique identifying number or characteristic. Here's a really simple gut check for this, right? Would somebody who knows the patient be able to identify them from what you're sharing? If the answer is yes, and if the info relates to health or payment for care, treat it as PHI, right? It's also important to remember that this doesn't just apply to things that have already happened, right? It certainly covers past and present care or payment for care, but it actually also covers future information, right? So if you learn, for example, that one of your patients has an upcoming appointment, surgery, whatever, that is also protected health information. So be very, very careful, okay, with any form of PHI that you end up having. Because as we'll learn later in the talk, um, big penalties for disclosure. Okay, so let's think about where PHI actually lives in modern EMS workflows because it is everywhere. We're talking about the EPCR platform, whether that's Image Trend, ESO, or whatever platform you happen to be on. If it's your CAD system, dispatch audio, cardiac monitor uploads from your LifePak or Zoll, or and whatever model you use, scene photos and videos, billing claims, EOBs, hospital face sheets, even verbal handoffs. Every one of those touch points needs some variety of safeguard, whether it's administrative, physical, or technical. And here's the piece that most people miss. The vendors who handle that PHR, your EPCR provider, your billing company, your cloud host, your secure messaging app, they are business associates, and your agency has to have a business associate agreement or a BAA in place before you share PHI with any of them. Okay. That is something that is pretty typical when you sign a contract with one of those vendors, but it's certainly something that you want to make sure that you have in place. So PHI shows up in three practical forms in EMS. Okay, hard copy paper, digital records and media, and verbal communication. The same HIPAA standards apply to all three. The thing is, field clinicians tend to safeguard digital pretty well, but the paper and the verbal stuff is where we leak. Open trip sheets on the dash, a conversation in the ED hallway, a debrief out at the gas pump in the parking lot, right? That's the exposure. So to give you an idea of what we're talking about here, when we say hard copy, we're talking about face sheets, PCS forms if you're doing like interfacility transports. If you get a hold of a paper PCR or a refusal form, that's hard copy PHI. Digital PHI, EPCRs, monitor data, photos, videos, emails, faxes, cloud storage, all covered by that. And then verbal, right? Our radio reports have PHI in them, bedside handoffs. And then if we happen to do like a critical incident stress debriefing, those can have PHI in them as well. So keep that in mind as you are moving through this. Let's talk about social media now, because this is the single biggest source of avoidable EMS HIPAA violations, period. Quick examples. In 2022, AMR, which is like the largest private ambulance company in the US, AMR in Arizona suspended an EMT over a Facebook post, even though the name and address were blurred. And in 2026, a lawsuit was filed in North Carolina alleging a former EMT photographed a critically injured patient on her personal phone. Cases like these don't just bring Office of Civil Rights. If you've heard me referring to OCR, that's what that means, Office of Civil Rights. They don't just bring OCR investigations down on the agency, they create personal civil liability for you and they end careers. Okay. Rule of thumb, even just commenting on a patient's public post can imply a treatment relationship and create a HIPAA exposure. So when in doubt, don't post and tell your colleagues not to either. Okay. Lots of liability there. Basically, your agency should have a social media policy. And if you are at all unsure about what you're posting, obviously refer to that, or just don't post it. Right? Just post your Instagram reel or your cool food photo and call it good. So going to give you a heads up on the May 2026 HIPAA security rule update. It just went into effect, and it has a lot to do with the encryption of electronic protected health information in transit and at rest, and it's now mandatory. So there's no more addressable carve out you can leave on, and those consumer messaging apps, SMS, iMessage, WhatsApp, Snapchat, they aren't HIPAA compliant for PHR even when they are, or sorry, PHI even when they are end-to-end encrypted. So why not? Because they don't have a business associate agreement or the audit controls, right? We don't have a signed contract with Snapchat saying we're going to use this and we expect you to protect this information. And let's say that I'm your EMS supervisor. I can't go in and kind of look and see who sent what to who and who's clicked on what, right? So you really need to stick with your agency approved tools only, secure messaging platforms. Some of those might be like Tiger Connect, Pulsera, or whatever is built into your EPCR as well. Okay. Do not, please do not send it through text or Snapchat or on a personal device at all. So these obligations are how OCR and your medical director are going to judge the decisions that you make. There's the golden rule, informal but pretty powerful, right? And it's essentially anything you observe on the call stays with you unless sharing is for treatment, payment, or operations, right? What you see here, what you hear here, when you leave here, it stays here. There's the minimum necessary rule as well, which is a formal HIPAA standard. Um, Basically just disclose the smallest amount of PHI needed to get the job done. An important caveat, though, minimum necessary does not apply to treatment disclosure. So your radio report and your bedside handoff can be full and complete. It does apply to pretty much everything else. So QA, billing, law enforcement requests, you name it. If it is not directly related to treatment, it does fall under that minimum necessary rule. Okay. So we've been talking about treatment, payment, and operations, and we're going to just call that TPO. And we're going to break that into three TPO buckets. So treatment, Share PHI freely with anyone else involved in the patient's care. That's medical control, the emergency department, transferring or receiving facilities, consulting specialists. The minimum necessary does not limit treatment disclosures, period. Okay. Payment, your agency can use PHI to bill payers, or also known as like insurance company, Medicare, Medicaid, that sort of thing. Run eligibility checks and handle claim audits. Okay, no patient authorization needed. Operations, this is your QA, QI, protocol development, training, credentialing, fraud and abuse compliance, population health work like overdose tracking, etc. Operations disclosures are limited by the minimum necessary, so you need to de-identify anything that you can. Anything outside of TPO, that generally needs written patient authorization or a specific HIPAA exception. Okay, so keep that in mind. Quality assurance is a permitted healthcare operations use of PHI. So case reviews, protocol development, training, they all qualify for using PHI. They don't need patient authorization for any of those. That said, the minimum necessary rule still applies. So you need to de-identify anything that you can. Those are those 18 components that need to be removed whenever possible. Okay. So keep that in mind as well. All right, we are on to part two, the field walkthrough. We're going to look at a chest pain call from dispatch to documentation. And this should kind of hopefully help you understand how a lot of what we've been talking about so far over the last 15 minutes or so actually applies to what you do day to day on a run. Okay. Dispatch traffic. This is one of the oldest HIPAA myths in EMS. Reality check right here, right now. HIPAA does not prohibit dispatch centers from sharing the info EMS needs to respond and treat. And people with scanners hearing your traffic, that's what we call an incidental disclosure. It is a permitted side effect of legitimate communication. That said, the minimum necessary rule still applies. Names and unnecessary clinical detail should not be going out over open frequencies when an address and a chief complaint will do the job, right? I mean, think about it. If I'm saying, medic one respond to 123 Main Street for chest pain, that gets me what I need to know to get to the scene. If I instead say, hey, medic one, respond to Bill's house at 123 Main Street, he is really having chest pain after he had a fight with his wife. Yeah, that's probably a little bit too much, right? That is more than we really need to accomplish being able to respond to that call. Um, Information from co-responding agencies is permitted for treatment, right? So you can share with other agencies that are on the scene. So the deputy's observations, the vitals, that piece of paper with the patient's name and date of birth, totally appropriate to receive. Just document the source in your EPCR. The other direction works too, right? You can share your protected health information back with your public safety partners when it's actually needed for the patient's care, or under one of the very narrow law enforcement exceptions, not just because they're curious about the call. So let's say, for example, that you went on an intercept with another agency, you can share information between each other in both directions. Where you might get a little bit sticky is sharing information from you as the EMS provider up to law enforcement about that patient's medical condition when they are not actively involved in their treatment, right? Because they're not there as a healthcare provider. We will talk about that exception here in a minute as well. Okay. So HIPAA gets it. Emergency scenes are not soundproof. You are allowed to speak with family, household members, or anyone the patient says is involved in their care. And that's especially true when the patient can't speak for themselves. Really, you just need to use your professional judgment about what's in the patient's best interest. Bystanders and media are a different story, right? Common sense. Take what they witnessed, but you really don't need to share any patient details ever. No comment. Please call our PIO is always the right answer for the media. And on scene, the best things that you can do are lower your voice, position your body, get the patient into the ambulance before any sensitive discussion happens whenever possible. Okay. You really want to do this, and that is minimizing those incidental disclosures whenever possible, right? We recognize that sometimes we cannot keep everything quiet or 100% private, but we need to try, right, as best as we can. Okay, so a few quick scenarios. Minors. PHR generally goes to the parent or legal guardian as the patient's personal representative, with limited state law exceptions. Think reproductive care, mental health, and substance use in some states. So, obviously, we're talking mainly about Wisconsin here. If you happen to be watching this in another state, make sure that you know what your state's requirements are, because uh, a lot of states have additional regulations in addition to HIPAA. You can also talk about incapacitated patients with someone reasonably involved in their care when it's in the patient's best interest, right? If you need to get information or find out which hospital they go to, or find out, what sort of care they might like, that is an okay conversation with a person who might know that. But if you're just talking to a cousin 3 times removed, they probably don't need to have that conversation, right? The other is an activated healthcare power of attorney. Once the document's activated, and that is the key, it has to be activated, and you have done something to verify it. Uh, the surrogate is the patient for HIPAA purposes, right? You can talk to them about anything that's going on. The key is that it has to be activated. Just because they have one in writing does not mean that it is activated. So make sure that you kind of make that distinction whenever possible. In terms of law enforcement, it's really pretty narrow in defined situations. We're talking about court orders, identifying a suspect or a missing person is one, reporting certain wounds, or an imminent threat is also a covered exception. More details on that as well. Here's the framing for state law. HIPAA, is the federal floor, right? Nothing can go below HIPAA, but states can certainly go above it. Wisconsin and a couple of federal sub rules add stricter protections in several categories. The ones that show up most in EMS are these: mental health, written informed consent for disclosures, even between providers, have to be in place. With some pretty narrow emergency exceptions. Substance use disorder records held by some federally assisted programs are pretty tightly controlled, and this comes up from time to time on overdose calls and interfacility transports. HIV results require specific patient authorization for most disclosures. Minors, state law may let them consent independently for things like mental health, contraception, or STI care. So, know the local rules before disclosing anything to a parent. Domestic violence and sexual assault, additional confidentiality, advocate notification, and reporting pathways apply. Certainly, there's some mandatory reporting stuff that can go in there depending on the exact situation as well. Genetic information, GINA plus state statutes restrict use beyond pretty ordinary PHI rules. The default rule is simple: whichever law gives the patient more protection is the one that you need to follow. Okay, so keep that in mind should you come across any of these. Some of these are pretty rare in EMS, others you might get more frequently, like some mental health or substance use information. Genetic information, maybe not so much. All right, so faxed 12 leads, EPCR uploads, cardiac monitor transmissions. We've already covered that. Those are all PHI. So when we say the most secure method, we mean agency approved encrypted channels, not a photo on a personal phone, not a consumer texting app. And remember, this rule that just went into effect in May of 2026, the May 2026 security rule update, makes encryption in transit and at rest mandatory. That means it has to be encrypted from start to finish and just when it's being stored. It's not something that there is an exception to any longer. Bedside handoff is a treatment disclosure, so the minimum necessary rule does not apply, but you still need to be respectful of people's privacy, right? Close the curtain, slide the glass door, keep your volume maybe low, conversational, right? And anything you take back to the truck, face sheets, labels, whatever, that's PHI too. and secure it like you would secure the EPCR. Okay. So just keep all of that in mind. Post-call activities, documentation, QA review, the crew debrief, critical incident stress debriefing, those are healthcare operations, so they are all permitted uses of PHI. Just have those conversations in a private space, not in the hallway, not at the gas pump, and definitely not on social media. Now, law enforcement disclosures after the call, those are really tight. You can share HIPAA protected information in some really specific circumstances, and you can share what a valid court order, warrant, or subpoena compels. Anything beyond that, that needs to go through your privacy officer. Okay, you should not just be handing over a copy of the EPCR to your local police officer.